Our last speaker of the morning is going to be Dr. Lauren Castleberry. Dr. Castleberry went to medical school at the University of South Florida in Tampa, and then did her residency in OBGYN at Rush University Medical Center in Chicago. I've already given her a hard time about that. I'm not sure I could have gone from Tampa to Chicago as a native Chicagoan, but it sounds like she's learned her lesson about Chicago weather. She's currently assistant professor of clinical OBGYN at the University of South Carolina at Columbia, and she's going to talk to us about abnormal uterine bleeding.
Thank you very much. Just so I can get a feel of who's in the audience today, how many of you are internal medicine? No. OBGYN? Awesome. Nurse practitioners? Okay. Nurses? Okay. Attending-wise? Physician? Awesome. Great. So I'm going to talk about this topic. I actually love this topic in terms of who I treat in the office setting. It's one of my favorites to deal with because it makes so much sense. So we'll get started. First off, I do not have any relevant financial disclosures to disclose. And today our goals are to go through the definitions and accepted nomenclature for abnormal uterine bleeding, to discuss the differential for abnormal uterine bleeding, and then use that to create a thorough workup. We're going to go through some evidence-based management guidelines and then discuss common scenarios that you might encounter in the office setting. So in order to know what abnormal is, you have to go through what normal is. And everybody here should know more or less what these definitions are, but just as a reminder, menstrual cycle that lasts between 21 to 35 days with a blood loss of less than 80 cc's, and the typical length of a menstrual flow being 4 to 8 days. And that's just based on the 5th and 95th percentiles of women who are polled. Abnormal bleeding would be anything that deviates from that, and that seems pretty common sense. In 2011, the International Federation of Gynecology and Obstetrics basically came up with a new way to describe and define abnormal uterine bleeding. And shortly after, ACOG ended up following this categorization, and they now use it and recommend it as well. But they took the terms that we were used to using, like menorrhagia, menometrorrhagia, oligomenorrhea, and they took that and made it a bit more descriptive so that the general public would have a better idea of what the physician was saying, and that the physician themselves, when communicating with other healthcare providers who may not necessarily do OBGYN on a daily basis, they also have an idea of what's going on. So they took menorrhagia and changed it to heavy menstrual bleeding, and menometrorrhagia changed it to intermenstrual bleeding, or IMB. And then they have additional letter qualifiers from the Palm-Cohen mnemonic, and we're going to go over those on the next slide. So with Palm-Cohen, first that initial heading is going to be abnormal uterine bleeding, and then describe what kind it is. Is it heavy menstrual or is it intermenstrual? And then they break up the mnemonic into the Palm and the Cohen side, with the Palm being primarily structural causes and the Cohen side being non-structural causes. So Palm standing for polyp, adenomyosis, leiomyomas, and the malignancy and hyperplasia. And then after your description of the AUB, just put a little dash with whatever the first letter of that word would be, so that way you can indicate what the cause is once you have found it. Same thing on the Cohen side, breaking up into coagulopathy, ovulatory dysfunction, endometrial causes, iatrogenic, and then N for not yet classified. And you may also notice that what is glaringly obvious from this setup is that there is no longer the term DUB. And I grew up with this term in med school and residency, and half the time I had no clue what it meant. The reason being, physicians, radiologists, reading studies, everyone would just say DUB for any sort of abnormal uterine bleeding, when that's not actually what the definition meant. So FIGO and ACOG alike said, please stop using this term. Don't use it to describe any sort of abnormal uterine bleeding. Forget it ever existed, because nobody really knows what they're referring to. If a patient went to the OR for fibroids, it was called DUB. If they went for coagulopathy, it was called DUB. Nobody really used it for what it was worth. So I'd encourage you to just stop using the word, toss it out, use the stuff that's much easier to remember: heavy menstrual bleeding, intermenstrual bleeding, and then a little indicator as to what the cause would be. So when it comes down to age-based differentials, we're going to see one that kind of goes through all different age groups, and that's anovulation. Primarily, this is the number one cause in girls age 13 to 18, and that's just from immaturity of the HPO axis. So the other potential causes in this age group are going to include hormonal contraception, pregnancy, never forget it. It's not uncommon. I'm sure we have all seen patients who are supposedly virginal that are actually pregnant, and they didn't know how that became that way. So I'd encourage you to always do that test, whether or not the patient tells you otherwise. PID, coagulopathies typically will present in this age group, and tumors as well. For the bulk of the reproductive lifespan, the number one thing is going to be, again, pregnancy. But again, here, you're going to start seeing this ovulatory cycles where PCOS is probably the most predominant etiology in this group. And then other structural lesions like fibroids are going to start taking place, hormonal contraception just because it's so widely used, and then endometrial hyperplasia will also start showing its face here, especially in patients who have a number of risk factors. And then from age 40 to menopause, again, you're going to see anovulatory bleeding. And that's just as they get closer and closer to menopause, their cycles are not typically as regular because they're not ovulating every month. Endometrial hyperplasia and carcinoma become more predominant in this age frame. And then on the other side of the spectrum, you also have endometrial atrophy. So you either have too much estrogen or maybe too little. And then fibroids, again, you might see here in this category as well. So as for the workup, you always, as we know, we always start with a very thorough history. This is directly from the ACOG bulletin, but basically, if you have a patient, predominantly adolescents, who is presenting with heavy menstrual bleeding, there was a study they did back in 1981 where they looked at all these adolescents being admitted to the hospital for heavy menstrual bleeding. And they found that up to 20% of adolescents that get admitted to the hospital for abnormal uterine bleeding or heavy menstrual bleeding actually have an underlying bleeding disorder. And they looked at that even further. Some other studies have shown that adolescents with a hemoglobin less than 10 have that same rate of about 20% will have an underlying bleeding disorder. So it's recommended that when you are going through their history that you do screen them for a bleeding disorder, because that will make a difference in terms of what labs you may add on to the panel that you otherwise would not do. So from the ACOG recommendations, they advise using this list of things to ask for, and any of these would comprise a positive screen. So heavy menstrual bleeding since menarche, any of the following, whether it be postpartum hemorrhage, surgery-related bleeding, or bleeding associated with dental work, and then 2 or more of the following kind of like small, soft factors: bruising 1 to 2 times per month, epistasis 1 to 2 times per month, frequent gum bleeding, and a family history of symptoms. So those are all things to just keep in the back of your mind, ask about when you're asking their family history, or just in general their review of systems, because with patients who do test positive here, you're going to add additional lab work to your orders. And then you always have to ask about medications. Some are very obvious, warfarin or heparin. It doesn't take a rocket scientist to guess that that might affect their bleeding. Birth control pills, a lot of times when a patient comes in the office and complains of abnormal uterine bleeding, it's not always the first nature to think that they're already on something like birth control pills, because you would just assume that they would be regulated. But oftentimes you'll find that that is in their history, and that may actually be part of the cause. And then the other stuff that patients frequently fail to mention, so there's herbal medications because they're very natural. Ginkgo biloba, ginseng, and even motherwort can increase abnormal uterine bleeding. So when it comes time to the physical exam, on the exterior, you're going to evaluate the patient for findings consistent with PCOS if they have that anovulatory cycle, as well as for other bleeding disorders. And then I would strongly, strongly, strongly recommend that any patient that ever comes to you with abnormal uterine bleeding, that you always do a pelvic exam, including a speculum exam. I actually had a patient about a year ago next month who came to me 32 years young, not high risk for anything that you could really think of. She had seen her physician in another state about 3 or 4 different times over the past year for irregular bleeding, was on birth control pills, and she and the physician both attributed it at different times to the birth control pills and just said, oh, it's her breakthrough bleeding. Well, she had just gotten married, had come off her birth control pills because she wanted to get pregnant, and then came to see me since she had just moved into the state, was a new patient. And I was like, let me just take a look. I know you thought it was birth control pills, but this doesn't make sense. You've been off it a month and a half already. Put the speculum in, and the entire posterior side of her vagina was eroded with cancer. And it was a stage 3 vaginal cancer. Not one bit of it touched her cervix. So please, please, please don't just assume it's their birth control pills. You always have to look for something else. And I would encourage that very, very strongly because it completely changed her life. And her physician had actually, she said, at least one of those appointments done a speculum exam, and I could see how they missed it because that posterior blade of the speculum probably covered much of it. And I was looking, I saw some clot and tried to move that away and saw it wasn't moving, and then when I pulled that blade back, you could see the entire cancer eroding through. So just please do a visual exam. Beta HCG testing. So a pregnancy test is very cheap, very easy to do, and again, even in the patient who says that they are virginal or not sexually active, it doesn't hurt to test. It's very cheap. A complete blood count is a generic testing that you're going to do in any of these patients. One, to see if their hemoglobin levels are reflective of the amount of bleeding that they actually say is happening. And two, to look for any platelet disorders or level abnormalities. TSH, so you can get that in both patients who seem like they have an anovulatory cycle or those who are bleeding too much or even too little. You can see it in all of them, so I pretty much get that routinely. Prolactin levels, plus or minus on this, you could probably save this for patients who seem to be primarily anovulatory and not just heavy periods every cycle as long as they're regular and seem to be ovulating. And then you can always do chlamydia screening in patients who seem to be high risk by whatever definition your high risk might be, whether they live in a high risk area or are in a high risk relationship. As for patients who you've screened for those bleeding disorders and they have tested positive, you're going to want to add some additional testing onto their labs that you wouldn't order in the standard other patient. So for these patients, you're going to add a PT, PTT, plus or minus fibrinogen, especially in the acute setting if you think that they're bleeding out. And von Willebrand testing. Usually, the lab will have a panel that you can order that will have all the necessary labs on that. But if they don't, then you can specifically write these three. And then bleeding time is neither sensitive nor specific and is no longer recommended or indicated for this. So continuing the workup, in a non-adolescent patient, get a pap smear. It's part of the routine screening, but again, how do you know that there's not something abnormal there? Certainly, in the adolescent or under age 21 patient, if you're doing their speculum exam and you see something abnormal in the cervix, I would definitely send cytology. But you're not going to do that routinely in the girls under age 21. As for endometrial sampling, it used to be when I was a resident, they said started at age 35 and older if they had abnormal bleeding, and then about a couple years later they changed it to 40, and finally ACOG says now 45. It should be a first-line test in women over the age of 45, but I know myself as well as many of my colleagues, we have a very low threshold for doing it in women under the age of 45 if they have any risk factors for developing endometrial hyperplasia or cancer. And that is almost ubiquitous in our day and age now since obesity is such a prevalent problem, and obesity is one of the major risk factors for endometrial hyperplasia. So I do not hesitate to do it in women under the age of 45 in that type of scenario. Other patients you want to do it on is if they've failed medical management or they have persistent abnormal uterine bleeding. So just a quick word about the endometrial biopsy. This is a meta-analysis that was performed in the journal Cancer, and they were looking at the use of an endometrial biopsy pipelle that you can do in the office to compare it with what you see in the operating room, either using hysteroscopy, D&C, and or hysterectomy. They wanted to see how closely accurate it was to detecting endometrial hyperplasia, particularly the atypical type, and or diagnosing cancer. And what they found was that it was highly sensitive. In the premenopausal patient, slightly lower so at 91%, but in the postmenopausal patient, it was almost 100% sensitive. And sensitivity for atypical hyperplasia was roughly 81%. The specificity was more than 98%, so this is something that is recommended. If you can do it in the office, it's quick, it's easy, they don't have to undergo the anesthesia. or go through a major procedure in the operating room or even a minor procedure. But initially do that, and if you can't, or if you fail that, you can't leave it be at that. You have to work it up further. You have to take them to the operating room or refer them to somebody who can to get some sampling. As for imaging, in the field of gynecology, the transvaginal ultrasound is our best friend. We do it on pretty much anybody for anything. So same case scenario for this, for abnormal uterine bleeding. It's not just to look at the uterus. Certainly the uterus can show abnormalities or anatomic abnormalities that will lead to abnormal uterine bleeding, but it's also looking at the adnexa, which you may or may not be able to feel on bimanual exam, and we're often told that our bimanual exams are not as accurate as we actually think they are. So you're going to be looking at the adnexa for any masses, fibromethecomas that can cause hormone-producing tumors and result in abnormal bleeding as well. Saline infusion sonograms are a really nice way to kind of lift up the transvaginal ultrasound and improve it even then some, and just about hits the level of hysteroscopy in terms of diagnosing endocavitary lesions. And I'll show you some examples of that in a second. For adolescent patients or those that you don't want to traumatize with a transvaginal probe, then you can certainly use a transabdominal ultrasound. And again here, especially, you're looking at the adnexa to make sure that there's nothing neoplastic there. Routine MRI is not recommended, so you would not do that as your first line. If you had a patient, say, who had multiple fibroids and abnormal locations, you're considering surgery on them, then yes, go ahead, get the MRI, but you're not going to do that initially. So a few things about pelvic ultrasound. Again, it's helpful to evaluate the myometrium, or the bulk of the uterine tissue. But when it comes to endocavitary lesions, the sensitivity and specificity is a bit lower, roughly 56 and 73%. Another comment about pelvic ultrasound is that the endometrial stripe thickness, you'll often read that on an ultrasound report, it means nothing in the premenopausal patient. And that's because that stripe and that lining changes and varies throughout the month. In a postmenopausal patient, yes, you can use it to your advantage to help triage patients, but in the premenopausal patient, it's pretty much worthless. And then the pelvic ultrasound, which I'll show you some pictures on the next slide, it is inferior to a saline infusion sonogram for detection of these intracavitary lesions, going back to that sensitivity and specificity above. So on a pelvic ultrasound, this is a beautiful picture of a trilaminar stripe here. You have this nice, in this case, retroverted uterus here, and this is the trilaminar stripe. All of this area here being measured from there to here is the endometrial stripe. And to be honest, although it looks beautiful, you don't know it could be lurking here in the growth of the lining. So if you do a saline, oh lordy, hold on one second. If you do a saline infusion sonogram, you put saline in, you distend the walls or the cavity of the uterus, and then you're clearly able to see either this polyp or myoma here. Might be better indicated if you were able to have some color flow on it to see if it has a stalk, but that would be the way to help indicate that this patient might actually be a better candidate for the operating room as opposed to just trying some medical treatment. So this is another point of contention I think I have for whenever my residents do it or even other colleagues, regardless of the field, but a lot of times patients will come into the office and they'll say, can you just give me something to stop my bleeding? And you haven't done your workup yet. You're like, okay, we're going to order an ultrasound. We're going to order some labs, but here's some Provera. And in a patient who is low risk for endometrial hyperplasia, that would be fine. You can do that to go ahead and stop their bleeding. But in a patient who is not or who has an increased risk of endometrial hyperplasia, you should not be doing that, not until you've gotten your workup done. It's a different scenario if that patient comes in with acutely hemorrhaging and they're in the hospital, their hemoglobin's low, they're needing a blood transfusion. But just for the patient that comes into the office, irregular bleeding, wants something as a quick fix or calls in over the weekend, you really should not be doing that. You could have the potential to change the pathology that's on their endometrial lining, as well as give the patient a false sense of security or relief that now their bleeding has stopped and they don't need to follow up, they're fine, when that's not actually the case. So if it's somebody who has a low risk for having anything bad going on, go ahead, you can start some treatment initially, but if not, you really should not be doing that. So going back to this Palm-Cohen flow, in terms of treatment options, they vary based on the etiology, and that would make sense. For polyps, you're not going to treat that medically. That's an anatomic abnormality. You can just go in and take that out. So refer to the people who can do that. For adenomyosis, again, it is an anatomic abnormality, but the only cure for that is hysterectomy. So until they get a hysterectomy, you can try using some different medical options or therapy. Fibroids, same thing. Either medical or surgical options, all the way from just putting a Band-Aid on it to complete removal. And then malignancy, again, most people, you would think that is a surgical management, but for patients who either still desire childbearing or are not good candidates for surgery, there are some medications we can use to help treat that. For coagulopathy, that's obvious, treat the underlying disorder. Ovulatory dysfunction, you're going to try and use medical therapy first, and I'm going to talk a bit about that in a second. Endometrial causes, either medical or surgical options. Iatrogenic, you're obviously going to stop what's causing the bleeding, and then for not yet classified, it ends up, you can try medical, oftentimes will turn into surgical. So I'm going to talk a little bit about treating anovulatory bleeding, because this is another one that's hugely important. You have to understand that the underlying disorder is endocrinologic. So if you fix that underlying disorder, you oftentimes fix the problem, which is why it's a very easy fix. If you get a TSH and it's off, then you can just fix the thyroid, and oftentimes their bleeding will resolve. For patients who, with the most prominent cause of anovulatory bleeding in the reproductive ages, that's PCOS. It's a little bit different, and we're going to go through that. In that case, you're going to be trying to manage the underlying disorder because you're never really going to cure their PCOS. But in these cases, you can do surgical therapy, but you really only want to reserve that for patients when their medical therapy fails, or when it's contraindicated or not tolerated by the patient. And then if they have any anatomical abnormalities as well, or some other intracavitary lesion. So I know we've all seen this at some point in our training, and don't worry, I won't get into it too crazily. But this is that typical menstrual cycle where the first 14 days is just that follicular phase here. And then you ovulate, and with ovulation, you get this rise in progesterone here, the purple. The second half of the cycle, obviously, we all know is the luteal phase. We are going to focus primarily on this level here. So if you're looking at estrogen and progesterone levels in the menstrual cycle, you're going to notice that clearly in the first half of the phase, your estrogen levels are dominating progesterone. And progesterone never really takes over and surpasses the estrogen levels until after ovulation occurs, and it's only with ovulation that you will get that. And so for those of you who might be internal medicine, family medicine, et cetera, and don't have the privilege of getting to see these patients in the operating room, this is a typical hysteroscopic view from that first half of the cycle. Patient's just finished having a period, the lining's not too thick, and it's just starting to grow. Second half of the cycle, progesterone dominant, so you have the lining has now grown and it's starting to become developed, so it can look enticing to that embryo when it comes along. I often use a analogy of comparing estrogen to a fertilizer and progesterone to a weed whacker. And the lining of the uterus is a field, or your yard, your garden. So with the estrogen dominant phase, you're going to have the field and the grass just starting to grow. With the progesterone coming in, it's going to be tweaked, and you're going to get this nicely manicured lawn. And it looks good. It looks ideal. But in a patient who has predominantly estrogen, so all they have is fertilizer, they don't have any of the weed whacker, they're going to be growing a lot of weeds. And every single day looks like Groundhog Day, if you've ever seen that movie. Nothing ever changes. So in these patients, you actually have a much higher level of estrogen compared to progesterone levels. You have weeds growing out of control because the weed whacker never comes around. And this is the picture you get. It's disgusting. This is endometrial hyperplasia inside of a uterus. And you can see stuff is all different lengths, not very well controlled. So for these patients who have estrogen being produced, primarily these are your PCOS patients, they're going to have a very thick lining of that uterus that grows at all different levels at all different rates. You know, if you have a yard, you have some weeds that grow really, really fast and others that don't. So when that one weed outgrows its blood supply or water supply, it's going to start to shed. And so as it's shedding, the other weed that hasn't quite gotten there is still continuing to grow. And then by the time this one has shedded and it's stopped bleeding, the other weed has now gotten to that same length and now is starting to shed itself. So these are the patients where you have a very desynchronized uterine bleeding, and that's why they seem to bleed for 2-3 weeks on end without ever stopping. One area of their uterus is bleeding, while the other one is still growing, and then it just keeps switching around. So that is something that you got to keep in mind with this PCOS patients, because when you go to treat them, aside from managing their PCOS in general and their insulin resistance, you also want to treat the lining of their uterus and help prevent them from developing that endometrial hyperplasia, which is the direct precursor to endometrial intraepithelial neoplasia, or atypical hyperplasia. So when you treat them, you're going to be working on thinning out that lining and protecting it from the hyperplastic transition. And with this kind of treatment, some of them are contraceptive, and so they have the benefit of kind of improving their endometrial lining and preventing that transition while they are waiting to or planning to get pregnant. On the flip side, say they do want to get pregnant, you can still do this in a way that doesn't prevent them from getting pregnant or cause contraceptive effects. So as for medical options for these patients, because again, that's the primary chosen method, you want to give them what they don't have, which is progesterone. So they're not developing it, you can give it to them. The levonorgestrel IUD is one option. Medroxyprogesterone acetate, Magestrol acetate, norethindrone acetate, and even the DepoShot are all different options that are progesterone only. And then combined hormonal contraception is another option that would also give them the contraceptive effect. And the way this works, as we all know, is it shuts down any potential for ovulation by shutting down the HPO axis and taking control by giving the patient a certain standardized dose of estrogen and progesterone. So as for surgical options, as we already said, it's not preferred as first-line management, but options that you could do are endometrial ablation and hysterectomy. I am not a huge fan of doing endometrial ablation on these patients or those that have an incredible risk for developing that hyperplastic transition, and this is why. So this is a patient that I did an endometrial ablation on, and you can see this is immediately after the ablation. All this tissue is kind of torn up, this little white area, this burned area. Most of the time when we're doing this ablation, we're using a device that will do kind of a panned out burn of the endometrial lining. There are some patients or some people who still use a roller ball. It's an older technique that you can get in there and kind of do the entire lining, and it's at your control and at your disposal. But most of our devices now include 2 different brands that will fill out as much of the cavity as it can. So when you're doing that, you may have some areas that don't get a full burn. And so those areas are still responsive to the hormones that are floating around in the system. So if it's primarily estrogen, again, that area is still going to respond. It's still going to grow. And then on the right here is a picture of a patient who came back after they've had an ablation, and that's just all scar tissue inside the uterus. That scar tissue can basically occlude the bleeding from coming out. So you have a patient who may have a small area that was not fully burned. It's still responsive to estrogen, and typically they would see a sign of that growing because they'd have abnormal bleeding, and that's how they would present. But in these cases, oftentimes, you find that they never do present, not with that abnormal uterine bleeding at least, because that blood is occluded from coming out due to the scar tissue. And so those patients actually can present a little bit at a more advanced stage of their endometrial cancer or hyperplastic transition. And so for that reason, I do not typically offer this to patients who are obese or maintain their risk factors for developing endometrial hyperplasia, because it's not safe for them in the long run. And I make sure that they know that, and that's why. As for hysterectomy, that's a fun one for me and for any OB-GYNs in the room, but that is a definitive management. This was a vag hyst that we did, and once it's one and done. So the problem with that is that they do have to undergo all the risks of surgery, and sometimes those same patients are not the best candidates for surgery either. So you really have to go through all their options with them. Now moving on to just abnormal uterine bleeding treatment options in general. The first one, Nsaids. It's not one that often comes to mind for most people, but it should, and I'll show you why. Tranexamic Acid is another one. Hormonal therapy, so that could be the pill, the patch, the ring, or even any of the progesterone methods. Uterine artery embolization, and then surgery as well. So with Nsaids, this is going to include ibuprofen, naproxen, and mefenamic acid. And the way that this works is it helps to decrease the rate of prostaglandin E2 and F2 alpha synthesis in the lining of the uterus. And this in turn leads to vasoconstriction and reduced bleeding. Some of the advantages of this, it's not hormonal. They do not have to take it every single day of the month. It is low cost. It can also help with any pelvic pain that they have during their cycle. And there's no increased risk of thrombosis. Benefits include a 20 to 50% menstrual blood loss reduction. And the efficacy of naproxen and mefenamic acid has been studied, and they basically found that they were very similar in terms of their effects. So as for the timing of the use, you're actually going to start this on the first day of the patient's cycle, and then you're going to keep going until their period stops. Dosing for that, I have listed it up here in case you choose to use it at any time. But what's interesting, ibuprofen is only once a day, about 600 milligrams. A lot of patients I have like this, they're also using it to treat their dysmenorrhea. So typically I'll have them even start 2-3 days before their cycle as you would to treat dysmenorrhea. But for strictly abnormal uterine bleeding purposes, they only need to start the day of their cycle and only take it once a day. As for tranexamic acid, this is a good option for women who either don't desire or can't use hormonal treatment. This is an antifibrinolytic agent that blocks the conversion of plasminogen to plasmin and leads to reduced fibrinolysis. Advantages for this is they can still use it while they're trying to get pregnant, so it doesn't have any contraceptive effect, and it's safe to use while they're attempting to conceive. And you really only take it during the menses itself. So again, you don't have to take it every single day of the month. Risks or things that are not so desirable is that here in the United States, it's extremely expensive. Even in the hospital setting, when you have to give it IV for acute bleeds, it's very expensive. So it may be cost prohibitive for the patient. And then the FDA they have labeled, the labeling history includes an increased risk for DVTs and PEs while the patient's on it. So typically, if you're using any sort of other hormonal treatment, you don't want to combine the two. But this is more of a theoretical risk and one that's listed by the FDA, but it hasn't been supported by any studies. I don't know that I would encourage you to test it out, though. Yeah, I mean, if it's a dire situation, you may consider that, but I probably wouldn't. As for the benefits here, it reduces menstrual blood loss by anywhere from 26 to 54%, which is fairly significant. And it has been shown to be more effective than Nsaids, but less effective than the levonorgestrel intrauterine system. Combined contraceptives include the pill, the patch, and the ring. There is only actually one oral contraceptive pill that has been FDA approved for heavy menstrual bleeding, and I'm not going to give the brand name for that, but it's basically a short interval hormone-free pill, so they have 26 active days and then 2 placebo days. Theoretically, you don't have to use that particular pill for treatment. You can use any of them because the theory and the concept is still the same. Obviously, the shorter interval you get, the more likely they are to have a lesser number of days with bleeding based on how that works. As for the advantages here, they have all the benefits of the birth control pill, patch, or ring, aside from the decrease in bleeding. So it can help decrease dysmenorrhea, acne, risk of endometriosis, risk of functional cyst development, ovarian cancer, uterine cancer, the list goes on. As well as it can also provide contraception for patients who do not want to be kept pregnant. The endometrial protection is also there for your patients with PCOS or excessive estrogen levels. And the risks here include an increased risk of venous thromboembolism. So I'm going to bring that up because it's something that I do always counsel my patients about, and surprisingly, or maybe not surprisingly, many of them are more concerned about this than they are about anything else. And so I always make a point of showing this to them. So how many of you know what a woman year is? Is that concept kind of fuzzy? I know I didn't get it the first time I saw it, but when you look at what a woman year is say in this case 10,000 woman years. So you're going to take 10,000 women and follow them over the course of a year. That's 10,000 women years. So if you take those 10,000 women in that 1 year, patients who are not pregnant, they're not on birth control pills, they have no known medical problems, et cetera, 1 to 5 out of them will just have a blood clot for whatever reason. If you take female patients, who obviously female, on birth control pills, the ring or the patch, and you put them on that and follow them for a year, 3 to 9 of them are going to have a blood clot. And again, the most common time for a woman to have a blood clot while on birth control pills, patch, or ring is going to be in the first year of use. If you look at pregnancy, that rate goes up substantially to 5 to 20. And then during the immediate postpartum time period, that risk is 40 to 65. And when you look at that and you try and point that out to a patient, like especially those who are not trying to get pregnant, and you tell them, look, I could either put you on this pill that, yes, it does increase your risk for a blood clot, but if you got pregnant and then delivered a baby, it's much, much, much higher in terms of your risk, and probably the highest time period in their life when they are to get a blood clot. When you show them those numbers, then they're like, oh, really? You know, I didn't know that. And then it kind of hits them, okay, this is actually potentially the safer option for them. So I try to stress that in patients, especially, you know, adolescents or ones whose their moms come in with them and they're worried about that blood clot risk, or they saw it on TV, the lawyer said to call, and I show them this. There's one particular birth control pill that's discussed ad nauseum on the TV, and a lot of people have stopped using it, but the risk for that one is at the high end range of the birth control pills. It's at 9. And so again, even with that one, I will still use it and just advise patients and their parents particularly of what that number is so that they know and they can be making an evidence-based decision instead of a fear-mongered one. So when it comes to combined contraceptives, the benefits here, it reduces the menstrual blood loss by 35 to close to 70%. The dosing here, you have a couple different options. You could either do a cyclic monthly withdrawal bleed. They could do extended months, so 3 to 4 months before they have it, or even continuous and hope for no withdrawal bleeds, although most patients are going to have some sort of breakthrough bleed here. As for progestins, we've briefly mentioned the LNG IUS, the DepoShot, and high-dose oral progestins. So for the LNG IUS, this is the IUD that contains progesterone, and primarily this is the 20 microgram dose daily administration. So this has been shown to decrease the risk of hemorrhage. It also will provide that very present progesterone presence inside the uterus to help prevent cancer, and has been shown to decrease their risk of developing that for 20 years after it's been removed. And it is FDA approved for heavy menstrual bleeding, as well as for contraceptive purposes. Risks here in terms of cost, it is cost heavy in the front end. So, you know, it may cost $800 or whatnot for the actual product, but if they actually use it for 5 years, it comes out to something like $12 a month. So if they can pay the upfront fee or their insurance pays it, it is cost effective over the long term. And it can have a higher expulsion rate in patients who have fibroids or are known to have fibroids. This is considered a relative contraindication. It doesn't mean you can't use it. It's just they need to be counseled. It's possible it might come out. It's more likely to come out or get self-exposed. As for the benefits, this one decreases menstrual blood loss by 71 to 95%. And that's huge. They can go to completely no periods whatsoever. And I did put the name brand in here just because there is only one. It is not yet generic. But this is a 20 microgram dose daily. As for Depo, this is the shot. So again, you can use any of these progesterones in patients with contraindications to estrogen. This also works as a contraceptive effect, and menstrual blood loss is dropped by about 49% after 2 months of after the administration. Risks here, though, are weight gain, and particularly with the 80% of PCOSers that tend to be on the heavier side, this may not be something that you're going for, especially if they're trying to lose weight. And then breakthrough bleeding is extremely common, especially in the first 3 to 6 months. So if a patient is very well counseled about that and they know to expect it, I feel like they are more accepting of that when it happens than if they had no clue that that's what would happen. And the dosing for that, we know, is every 3 months. High-dose oral progesterones, you can use those as well. There's a couple different ways you can do that. You can give them either daily, every single day of the month, cyclically, so it does not have the contraceptive effect, and so they still get a period every month on a timed basis. And if you give them these medications continuously for 2 months, that has been shown to decrease menstrual blood loss by about 1/3. At super high doses, this can increase your risk of venous thromboembolism, but the lower standard doses do not. And then norethindrone acetate and medroxyprogesterone acetate, these are the lower dose of that would be the 5 to 10 milligrams. That higher dose, 30, I have never actually used. I'm sure somebody has, but you can go up as high as 30. So when you break it down into what all these different levels and how much they drop the menstrual blood loss by, you're going to find that one stands out more than any others. And it's pretty impressive. So even for the patients who initially come in and they're somewhat averse to having something inside their uterus, when you show them these numbers, a lot of times they're like, you know, anything to get my bleeding stopped or under control or whatnot. And they'll oftentimes try this, and they, for the most part, love it. I think the success rate or patient satisfaction rate is somewhere around 90%. So in terms of those options, you know, the most successful one, although certainly it's not for everybody, especially those who may not want the contraceptive benefit, but it's definitely something that you should know about. As for the other options, you always have uterine artery embolization, which is an interventional procedure with radiology. Surgical interventions can be anything from as low as a DNC with hysteroscopy to take out any fibroids or any polyps that you see in the endocavitary area, to abdominal myomectomy, which is more of a temporary fix for those fibroids. Patients need to be counseled that oftentimes they're going to require a future C-section in terms of their future fertility, and that their fibroids can come back. Endometrial ablation is minimally invasive. That's another, we discussed that briefly, but this one has an efficacy that is similar and equivalent to the LNG-IUS in terms of reducing menstrual blood loss. The only thing I would caution you again here is to make sure that you're giving it or performing it on the appropriate patient. And hysterectomy, again, this is what a lot of patients come in thinking they want, but then when they hear about the risks of surgery, they might back off to either the IUD or other form of minimally invasive treatment. So we're just going to do a couple of cases here. First one, this is a typical standard patient I'll see. 17-year-old G0 patient. She comes in with complaints of increasing blood loss with her menstrual cycle over the past 1 to 2 years. Her cycles last about 5 days, and they're heavy on the first 2. She's never required hospitalization or a blood transfusion, but just thinks this is annoying to her. She's not yet sexually active, or so she says. She denies frequent bruising or other complaints of bleeding, and she'd like to discuss her options with you. Her medical history is uncomplicated, as is her family history. She doesn't have any history of blood clots, bleeding disorders, any of that, and she's not on any sort of medications. So how'd you work up this patient? Oh yeah, always start with the urine pregnancy test. Absolutely. Somebody mentioned that in the audience. And we'll have the little box to go around to if anyone wants to answer in that. But yeah, certainly labs. I always have the urine pregnancy test before I even go in the room on a patient like this. But beyond that, I'm also going to be starting with their physical exam. So on physical exam, her BMI is 20, her vitals are normal, and she's an otherwise normal-looking girl. Speculum exam, beautiful cervix there. There's no anatomical abnormalities either on the cervix or any of the vaginal sidewalls. And on bimanual exam, there are no palpable masses, and she has a 6-week sized uterus. So I heard urine pregnancy as a lab that we want to order. Anything else? TSH, somebody said. Prolactin. So prolactin in this patient I actually would not do, and the reason is she is having a regular cycle every single month, so there's nothing there that indicates to me that she is anovulatory. So I likely would not do it as a first-line test. Certainly if I'm treating her and nothing's coming back abnormal, then I would. CBC is another test, and on that we're looking for both the hemoglobin level and the platelet level. I think. I'm sorry? Anyone else? No? Okay. So before you even order any of that, I did mention in your history you've asked a few of these things. She has not had heavy menstrual bleeding since menarche. She says it's just in the past 1 to 2 years. She says never been pregnant, so she's never had any postpartum hemorrhage, no surgery-related bleeding or bleeding associated with dental work, and she doesn't have any of the other soft factors in terms of screening for these bleeding disorders. So urine pregnancy test, TSH and CBC is what I would start with on her. Urine pregnancy test is negative actually in this scenario. Her TSH is normal, and her hemoglobin is 10.5, so it's not super low, but it is indicative that she is bleeding like she says she is. And her platelet count is normal. So do you need to do an ultrasound on her? So yes and no. If you have done, I know I said that the bimanual or the pelvic exam is not always typically reliable, but in this case, you may be able to get away with not doing an ultrasound on her because she's just complaining this is a gradual thing over the past 1 to 2 years, and you didn't feel anything on bimanual exam, which she is a relatively thin girl. She's 20. Her BMI was 20, I'm sorry. And so you'd likely feel a mass in there if it was there. And the little fluffier girls, I'd probably definitely get an ultrasound, but you wouldn't be wrong to get an ultrasound, but you don't necessarily need to do it as part of your first line management here. Does she need an endometrial biopsy? No, not at all. She doesn't have any risk factors for hyperplasia, so don't even bother. And then can you treat her without any of the above? Yeah, absolutely. So we said that in a patient who doesn't have any risk factors for endometrial hyperplasia or anything bad for that matter, you can go ahead and start treating her. I did have a patient similar to this my first year out from residency. She was about 20 years old and had been having irregular cycles, and she was seen initially at a different free type clinic. One of my colleagues treated her there, put her on some birth control pills, and said initially she was doing fine, but then kept having that breakthrough bleeding. So she got an ultrasound on her, and she felt a pelvic mass as well on her exam. Ended up she had a nice about 8 centimeter solid mass in her adnexa that was a fibrothecoma. And so it was producing additional estrogen, which was causing her irregular breakthrough bleeding even on the birth control pills. So if you have a patient who's not responding like they should to these birth control pills, then you certainly need to look a little bit further and get that ultrasound if you didn't already. So in this case, would the preferred treatment be medical or surgical? Medical. And why is that? You have nothing surgical at this point. There's nothing wrong on her physical exam. There's nothing that shouts to you fibroid or adnexal mass. So you can go ahead and just try and give her a shot at medical treatment. And what's the most effective medical option you can offer her? IUD. Yes. So a lot of providers that I've seen or met, they often, and I think we're moving away from this, but a lot of times they don't consider the IUD as an option in younger girls, especially virginal girls or nulliparous girls. But that is not a contraindication, and you most certainly can put an IUD in these patients. If they are not amenable to doing it inside the office, you can always bring them, do it under sedation if you want, or even give them local anesthesia in the office with a cervical block. But primarily here, the biggest thing is you want to make sure that their IUD will fit inside their uterus. So if they have a uterus smaller than 6 centimeters, not recommended for the standard 5-year progesterone containing IUD. There is another 3-year one on the market by the same company. The only difference with that one is, even though the size or the length is pretty similar, the width of or the diameter of the shaft of the IUD is slightly smaller by a couple millimeters. But in their package reading, it does not give you a limitation in terms of the sounding size of the uterus. Whereas with the 5-year, it says anywhere from 6 to 10 centimeters recommended. For the other, it says it doesn't matter. Having said that, you'll have patients with either a slightly larger or slightly smaller uterus. You can counsel them on that 5-year IUD because it is better in terms of blood loss than the 3-year. But I typically just counsel them because your uterus is outside of that standard defined definition or area, it is more likely to be expelled or expulsed. So you can offer it certainly to them, but just let them know about the potential for expulsion. And by what percentage should her bleeding improve? What's that? I always tell them, or I'll always say roughly 80 to 90%, but I think we have 71 to 95% are the actual statistics for it. And you want to let them know there are different bleeding patterns that they might see with it. About 1 out of 3 of girls or women stop getting a period entirely, and For a lot of patients, they are skeptical of that because they think that they should have a bleed every month to clean things out. I explain it to them as inside of this device is progesterone that I tell them is the weed whacker, and I describe the whole scenario for them, and they get it. But in other ways, it's just a duster. They have a house cleaner inside their uterus at all times, so the dust never builds up. So they don't have to have a bleed all the time because that lining is so beautiful. So the other 1/3 of patients will get a period on a regular basis, but again, 70 to 90% less blood loss. And then another 1/3 might bleed here and there, unexpected, unanticipated, but typically just on the spotting range every 3 to 4 months. So second case, this is a 47-year-old G2, P2. She comes in with complaints of heavy and irregular menstrual bleeding. There is no consistent frequency to them. She may bleed anywhere from 3 to 21 days at a time. She's required a blood transfusion in the past and desires definitive management. She's mutually monogamous with her husband, and she wants to discuss her options with you. So her medical history, she is obese and has hypertension. Surgical history, she has had a tubal ligation. And family history, her mom and sister both had fibroids, which we know has a genetic component to them. She's on hydrochlorothiazide. And how would you work up this patient? Physical exam, exactly. Never forget that physical exam. So on physical exam for her, her BMI is 40. Her vitals are normal. Her blood pressure is well controlled, at least on today's visit. And speculum exam, you again see a very normal, beautiful cervix. On bimanual exam, though, her uterus is about 20 weeks in size with some bulky enlargements. So what labs and or imaging do you want to order? CBC. What else? TSH, great. Pregnancy test and transvaginal ultrasound with or without abdominal? Oh, SIS, saline infusion sonogram, yes. Endometrial biopsy, absolutely, absolutely. Anything else in this girl? Do you think she's ovulatory or anovulatory? Anovulatory, so what other tests might you do? You could do an FSH, but your history already tells you she's not got a cycle. Prolactin? Somebody said absolutely. So pregnancy test, TSH, hemoglobin A1C just in the screening test for diabetes, because again, that might somewhat throw things off, and since she is obese, sometimes I'll do it in case they don't have the primary care doing that for them on a regular basis. Prolactin, CBC, plus or minus on the gonorrhea and chlamydia. I say that because she thinks she's mutually monogamous with her partner, but you don't always know. So I do tell them, because you don't want to upset them with either the bill that they see from their insurance when that test was done and they didn't know about it and they are certain to think that that's not the case, or if they end up having a positive test result, always let them know, technically this is part of that workup, and I know you feel very comfortable in your relationship, so I don't want to rock that boat. Do you want to save this test for later, or do you want to go ahead and do it now? Because if stuff is not settling itself out, we are going to do it later. And usually they're amenable to that. Some tell me, yeah, go ahead and do it now. Others say just no, skip it. And then a pap smear if it's not up to date, pelvic ultrasound we mentioned. And I added on here age-appropriate screening tests. And this is just for the surgeon in me who's thinking ahead that we might go in there and do a hysterectomy at some point. You don't want to get in there and find out that these masses that you thought were some sort of ovarian mass are actually metastatic breast cancer or metastatic GI colon cancer. I've definitely seen that, thankfully not in my own practice right now, but in residency training we certainly saw it plenty. So you want to make sure that they're all up to date with their age-appropriate screening. Does she need an ultrasound? Yes. Does she need an endometrial biopsy? Absolutely yes. She has multiple risk factors for endometrial hyperplasia. She's age over than 45, she's anovulatory, she's obese, diabetic, and hypertensive, each of which is considered a risk factor for endometrial hyperplasia. Is this the patient that you're going to send home with some Provera to just help her bleeding? No, 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 no. Please don't do it. Please don't do it. Work her up completely before you even consider that. So her urine pregnancy test is negative, her TSH is normal, her hemoglobin A1C is not so beautiful, it's 6.5. Her prolactin is actually fine, and her hemoglobin is 9 with normal platelets. Her pap smear is normal with a negative high-risk HPV testing. So this is her ultrasound, and basically you can see these little calipers here kind of pointing out where the massive fibroids are in her uterus. She has one really big one here at the fundus that looks like it's subserosal, and this other one over here that likely is intramural. So on endometrial biopsy, what you perform, it's proliferative endometrium with no evidence of atypia, which is shocking in this patient, but it happens. And in this patient, is the preferred treatment medical or surgical, and why? Any thoughts? Surgical, certainly, she has a reason for that. She has fibroids. You could try medical therapy first. I know she has the fibroids, but some people you might be able to hold off, particularly her. She's in her 40s. You might be able to put that Band-Aid over and help that bleeding enough that she doesn't need surgery until she hits menopause. But you do have an anatomic abnormality, which is likely the cause of her bleeding, and you do have a negative endometrial biopsy, so you certainly could try medication first. And what medical options are available to her? Would you do birth control pills containing estrogen? Now, I probably would have not in her hypertensive state. Even though it's controlled, it's category, I believe, 3 by the WHO in terms of starting that in someone like her. Main thing, you want to do progesterones. You know that you saw she has a proliferative lining, so she's somebody who's gearing up to develop that hyperplastic transition. So I would strongly, if she wants to go for medical options, I'd strongly counsel her on the progesterone IUD or oral progesterone, but something that's going to help prevent that transition. Nsaids, I put plus or minus. If she was a patient who was having a regular cycle every month and knew when it was coming or knew she could help predict it, that might be better in terms of using Nsaids than somebody who's it's happening all over the place. Because this is, again, that anovulatory bleed, you need to fix that underlying problem. Tranexamic acid, I would not likely do it in her, given her obesity and her age, which is both increases her risk for DVT and PE. But in somebody who didn't have those issues, you could certainly try that in somebody who has fibroids. And what other interventional or surgical options can you offer? Yes, I did not list that here, but absolutely. When I said interventional, I was thinking all surgery, but no, weight loss, absolutely. I strongly counsel them on that. Especially, too, if they're ever considering any sort of future surgical intervention. I want them to know that the impact that their weight has on them during surgery and post-surgery. You could do a uterine artery embolization, especially since there's a fibroid component. It's not going to fix the anovulatory bleed aspect of it, but it may help with the fibroids. Endometrial ablation, choose to asterisk on that. I would not do it in this patient because of her anovulation. If it was simply that she had regular heavy cycles or heavy menstrual bleeding due to fibroids, I would not have a problem offering it. But in this patient who is obese, who has multiple risk factors for endometrial hyperplasia, I would not offer this in her. Myomectomy, if she's done childbearing, which she had a tubal ligation, then I'd tell her that's also a waste of time. I don't know why you would do that in a patient who is done childbearing if you're not going to do a hysterectomy. You're putting them through all the same risks of the procedure for very little benefit or reward except for keeping their uterus just to eventually develop cancer. So it's true. I mean, I had a patient once actually who told me that she was from Mexico and she had her uterus taken out around age 25 or 27 after she had had 3 children. And I said, oh, why? Did you have fibroids? Did you have heavy bleeding? Did you have cervical cancer or something? She's like, no, my doctor told me that the uterus is just to have pregnancies and to get cancer. And so when she was done with her pregnancies, he took out her uterus. So I wouldn't go that extreme on it, but I do tell patients that if there is no benefit for it and it's causing these problems, don't leave it in there with a myomectomy. Take it all out. It's just sitting there waiting to develop cancer in her particularly. So given her desire for definitive management and her comorbidities might be her best option. Surgery, yeah. So I would hiss that. So in conclusion, Palm-Cohen is the new classification system that we're using for abnormal uterine bleeding. Please never use the term DUB ever again. There are better ways to describe it. And a thorough workup will help evaluate for both structural and non-structural causes, and you can use that Palm-Cohen mnemonic to help give you a good differential to start with. And medical treatment, or the medical treatment that has the greatest reduction in menstrual blood loss, is the levonorgestrel intrauterine system. So if you're not using it, you're not doing it enough.